I hate doing these bits because I get so absorbed in the sessions, I forget I'm supposed to be taking notes to reflect back on at the end. So I've made some hurried notes from my recollections of the morning. So forgive me if I miss anything particular out. But I think it's been an amazing session. I mean, I give you my congratulations for being here for 3.5 hours. And listening to all of us. But I think it's been a very rich morning of sharing experience and understanding. And we started, and I suppose the first thing I would want to say is that, whilst we talk about this partnership model, and if you've sat here for the whole 3.5 hours, you might think that what we're saying is that the partnership model is the answer to the workforce problem. It isn't. It's an answer to the workforce problem. And it's part of the toolkit which we can use as we seek to address the shortage of health workers and the appropriate training of health workers. So thank you to PAP for setting the scene for us this morning and underlining the challenge of the shortage of workforce and that we can't possibly achieve universal health coverage without an appropriately trained and resourced health workforce. And then for throwing out some challenges to those of us that are closely involved in partnership work, particularly the challenge around primary healthcare and the need for primary care to have equal, if not greater, emphasis than some of the work that we do around tertiary care. And then we moved on to what I thought was an excellent contribution from me, describing the UK experience in the health partnership scheme and the DFID funding, and then expanding a little bit on how we translate that from the individual experience of a volunteer who might work on a particular project, but how those projects when you take them all together and you scale them up, can begin to make a difference at a systems level. And then we talked, and then Luciano, the thing that we'll remember from what Luciano said was about, first do no harm. And I think let's just root ourselves in that, because I've been in discussions in the US in particular around some of the practices around medical missions and those sorts of things, which is an entirely different subject, but many of you will be familiar with. And I would love some of those organisations to understand that they should first do no harm. We then talked about the experience between the Mozambique government and the Irish government. So looking at this whole partnership model at a completely different level, government to government, and how exciting that is, and how we would all wish that could be replicated in so many other governmental settings. But it was a real treat to understand how that has evolved over the years and how it continues to evolve and to flourish. Then we talked about the need for evidence. Again, there was, I thought, a wonderful contribution from me. And then we talked about the effect tool, and Vicky and Emma explaining the work that's gone behind that. And thanks to Rosemary, where are you, Rosemary, for talking about your experience in using it. And I think what we can all take away from that is it's 45 minutes of your life well spent. So take it away. And do go through it and use it. And then we had the final session, and very helpful to hear about the work of CASEXA and the partnership with RCSI. Nikki, where did that come from? Health workers in disguise. I think that was fantastic, and the use of that medium of music to address health issues, and that they are health workers in disguise, and I absolutely love that. That's fantastic. And I think what the other thing was, as you said, there was a project log frame is never going to be an algorithm of real life, and Yes. Those of us that have to live and breathe log frames and theories of change and work with donors who are very insistent about how precise you are with your log frame, I think I'm just going to put that above my desk somewhere to ground me. And then the experience of the Zanzibar partnership with Norway and the reduction in maternal mortality and the increased availability of blood, which has taken place because of that, and the weaknesses that you acknowledged as well, really are very, very helpful. And then just throughout the morning, we've had these wonderful 3-minute presentations, which have kind of brought things to life. The real experience, the experience in the field, on the ground, of how this works out. They've been enlightening, and I just want to, I think what the UCD physiotherapy presentation we had right at the end demonstrates for me is that there's so much about these partnership activities that can be a real test bed for innovation. So we talked about e-health and various other things around innovative approaches that probably you couldn't do at large scales. That gives you that opportunity in a small scale setting to try something out and then scale it up. And I think that, to come back to a question that was raised right at the end, I think, about how does all this fit in with national health priorities. Our experience is that all of the partnership work we do and we support is in line with national health priorities. But even though it's small scale and working institution to institution, when you take the totality, for instance, in Uganda, where we've had 42 or so partnerships working, we now have a partnership office operating in Uganda, which has a relationship with the Ministry of Health. And so there is that flow of information both ways between those partnerships, which individually would not have access to the ministry, and it wouldn't be wise either, 42 people knocking on the door. But it does allow opportunities for things to be replicated across the country, and we're seeing quite a lot of that. So I think, thank you very much for your patience and for listening to me for so long.